this last panel is something I call super pearls, and it's really fun because usually the faculty aren't aware of this, but I'm going to ask them to, in like 30 seconds or less, to say if they could teach one thing, if there's one important concept, what is it? What do you want these people to go home with? And it can't be a long diatribe, it's got to be short and sweet. My short and sweet super pearl for this year is, gosh, we should really keep track of these and write them down, but we could go through the videos and do that. Anyway, my super pearl is this. In patients with nasal polyps, we all do nice surgery and you put them on budesonide irrigations or whatever you tend to do, and then you start to see the polyps coming back in some patients. And when that happens, they're asymptomatic at the time. You're like, okay, we better watch that. We'll see you back in a couple months. And then after that, they come back, and now they're symptomatic, and the polyps are bigger. And you're like, well, maybe we should do Sinuva or Xhance or something like that. My pearl is to intervene earlier. When you see those polyps coming back in those patients, do something then. Don't wait until they're bigger and symptomatic. Do a Sinuva, do Xhance, do double-dose budesonide irrigations. Whatever it takes, intervene earlier before the patient's symptomatic, because I think we can make a difference in those smaller polypoid or grade 1 polyps. That's my intervention, and I have changed my practice to using that more aggressive approach to patients before they're symptomatic, and I've been happy with that. Dr. Ray.
Cover your mouth when you sneeze.
All right.
Now, manage your patient's expectations.
Faria.
Doug stole mine. I was going to say that, but I'll come up with something else. I think letting patients know that chronic sinusitis is a lifelong issue, and it can, yeah? Oh, you can't hear me? Okay, sorry.
Yeah, it's on. You just have to stick it in your face.
Okay.
Is that
better?
Get COVID.
Okay. Okay. So I was just going to say that kind of what Doug was saying, piggybacking on him about managing expectations, is to let patients understand that chronic sinusitis, the chronic inflammatory subtype, is a lifelong process. Almost like I tell them it's like diabetes and hypertension. It'll wax and wane. There'll be periods where you're doing fine, periods where you're doing bad. So it's going to be like a journey. So I try to make sure they understand it's not a one and done thing. You'll get this one course of antibiotics or one surgery and then you're cured. So that's my pearl.
Thank you. Amy.
My pearl is a surgical pearl, and that is to pause. So when the bleeding is in your field and you can't see and you're frustrated and you just want to get into that maxillary sinus or whatever it is, and it's just not going right, and you can feel your blood pressure going up and your heart rate going up, just pack it off, just irrigate, just pause. And then if it turns out that it's just too bloody and it's just too much of a mess, live to fight another day. I don't think anybody's gonna fault you ever for stopping a surgery and coming back another time. So I think, remember, there's just no shame in pausing, and there's no shame in living, fighting the good fight another time.
I also have a surgical pearl, and I base this on the number of revision cases that I have to do. The maxillary sinus is the most challenging sinus to open up, and so use an angled scope. Get a reverse post 30, get a reverse post 70, and use those and make sure that you're in the natural ostium.
Amber. What's a super pearl?
Wow, I look very, very intimidating behind you guys. But I would echo what Dave says about the maxillary sinus, but also I have a whole new respect for the middle turbinate. I think when I first started out, everyone was so conscientious about respecting the middle turbinate, don't touch it, whatever, whatnot. But that's where my failures have been, where I didn't really manage the middle turbinate very well. I either didn't make sure that it was going to be medialized or resect at least a third, sometimes even a half of the inferior aspect, especially if it's polypoid in nature. And so that's one thing that I've really learned a lot from.
Dr. A has a follow-up super pearl.
Following up to what Amber said, and we never really talked about that this week, For revision polyp patients, don't be afraid to take the middle turbinate.
I agree. All right. With that, thank you to all of my faculty who made it here and gave up their time, donated their time to come and support this course. I really greatly appreciate it. We couldn't obviously do it without you. And thank you to all of you as well for coming and supporting, and the repeat participants. I love seeing you all once a year, and we will do it again next year, roughly at the same time. I know there's some questions out there. All of us will stick around and happy to answer questions afterwards. I want you to enjoy lunch. Amber, thank you for joining us. Take care, be safe. See you soon. Thanks, everybody.
Bye.